Our third pediatric neurology lecture will be about movement disorders. We will start talking about ataxias. Our first ataxia is ATAXIA-TELANGIECTASIA. In this disorder, ataxia is not always the presenting finding, and ataxia may be a much less prominent early symptom than upper extremity chorea. However, the chorea is usually less disabling ultimately than the ataxia. Dystonia, which is often a proximal feature, may be present. It is most commonly due to mutations in the ATM gene on chromosome 11q22-23. They often have significant sinopulmonary infections and can have hematologic malignancies as well, and the screening test for this disorder is an alpha-fetoprotein level. As you can see in these pictures, this individual has telangiectasias in the eyes, in the mucosa of the mouth, on the ears, as well as on the skin. Our next ataxia is acute cerebellar ataxia. These patients have a rapid onset of cerebellar dysfunction, which manifests primarily as a gait disturbance and incoordination. The mean age of presentation is 4.8 years. They typically have a prodrome of a febrile illness, which can be caused by a variety of infectious diseases, including varicella, mumps, mycoplasma, Epstein-Barr virus, enterovirus, or parvovirus. You can also see this after immunizations, such as immunizing for varicella, hepatitis B, or rabies. Usually they recover within about 2 weeks, and most make a complete recovery. If they do get imaged, and the neuroimaging is typically normal. Our next ataxia is Friedreich's ataxia. The clinical features include an onset before 25 years of age. They have a progressive gait and limb ataxia, dysarthria, absence of reflexes. They have a sensory loss due to neuropathy, muscle weakness, dystonia, a cardiomyopathy, scoliosis, sensory neural deafness, diabetes, and an optic atrophy. It is caused by a trinucleotide repeat of GAA that causes an expansion in the first intron of the FRDA gene on chromosome 9q13-21. It produces a gene product called frataxin, and the prognosis is determined by how severe the cardiomyopathy is in the individual patient. Now we're going to move on to talk about choreas. The first is Sydenham's chorea. This is the most common cause of a secondary chorea in children. The onset occurs weeks or months after an acute infection with group A beta hemolytic strep and is one of the cardinal symptoms of rheumatic fever. The symptoms may persist for weeks or months, but the chorea almost always resolves spontaneously within 6 months. The chorea typically involves the distal hand muscles, where they have a, quote, piano playing pattern, where it looks like their fingers are moving such as to play a piano, but they can have other forms, including a ballism, where their hand and arm just flings out suddenly. Anti-basal ganglia antibodies have been found in some children, and it has been hypothesized that this antibody production occurs because of a molecular mimicry by the streptococcal antigens. The chorea does not always require treatment, but if it is severe, then Depakote, Topamax, Clonidine, or some neuroleptics such as Risperdal have some benefit. I personally use a lot of Topamax in this setting. Now we're going to talk about tics. Tics are the most common movement disorder that we see in children. The definition of a tic is a repeated, sudden, stereotyped, discrete, intermittent movement Motor tics involve skeletal muscle, and phonic or vocal tics occur when a movement involves the diaphragm or laryngeal and pharyngeal muscles so a sound is produced. Tics occur many times per day, nearly every day, and they can change in anatomic location, frequency, type, complexity, and severity over time. Some examples of tics, as far as motor tics, simple ones include blinking, opening the eyes or mouth very wide, twitching the nose, grimacing, jerking the neck, elevating the shoulders or rolling the shoulders, closing the eyes very tightly, shifting eyes from side to side, grinding the teeth, or tensing up the abdomen muscles. Some more complex motor tics include shaking the head back and forth, flexing the trunk, scratching things, touching things, tapping the fingers, hitting things like the wall, jumping up and down, kicking the feet out, or doing gestures of various sorts. If the gestures are obscene, then that's termed copropraxia. Some examples of simple vocal tics include sniffing, clearing the throat, grunting, squeaking, humming, coughing, blowing, or making sucking sounds. More complex vocal tics include speaking a syllable, a word, or a phrase, shouting out obscenities or profanities, which is called coprolalia, repeating words of other people, which is called echolalia, or repeating a final syllable, word, or phrase of one's own words, which is palallalia. Tourette syndrome has the following diagnostic criteria: the presence of multiple motor tics, the presence of multiple vocal tics, or the history of such, that has started at less than 18 years of age, and both have been going on for more than a year. For most people, the tics start between about 3 and 8 years of age, and a lot of these kids will also have OCD symptoms, anxiety symptoms, and ADHD symptoms, but that's not mandatory for the diagnosis. Many of them have trouble in school, and it's likely due to a variety of genetic and environmental mechanisms. And the good news is that 85% will experience a reduction in their tics during adolescence. Treatment of tics, for mild, not particularly disabling tics, we typically just observe. And my criteria for that would be that the tics are not bothering the child, not causing significant disruption in the classroom, and are not leading to significant teasing by other children. If any of those things I just mentioned are a significant problem, then it's reasonable to consider treatment. And the primary medications that we use would be clonidine or guanfacine, either in a regular release form or an extended release form, Topamax, or neuroleptics. It's important to remember that complete elimination of the tics is generally not possible. The goal is to settle them down to a point that the child is in a more functional situation. Here are references, and this concludes our lecture on movement disorders in pediatric neurology.